record to this. Okay, because last time I did this study session, I forgot to record. So I'm recording it now. If you're not able to get into my free community, I'm obviously busy doing the study session, so I might not be able to give you entrance, but at least you'll see it here, and then you'll be able to see my screen once you get into the free community. So yeah, I'm gonna give everybody a couple minutes because it's 3 o'clock my time, 6 o'clock East Coast time. What are we studying? We're just gonna try to get through 25 random practice questions on Lab CE. If you don't know what Lab CE is, or if you've never heard of it, you've never used it, Lab CE and Media Lab are the same thing. Media Lab is the parent company of Lab CE. Media Lab is something that they give to facilities to use for competency, for SOPs, and for exam simulators. They buy like the whole package for their students and um, for their staff to maintain their credentials, so the CEUs and stuff like that. If your facility does not have that, I highly, highly suggest it's $99 for 2 years. Invest in the Lab CE or Media Lab exam simulator. It's an exam simulator. You have access to over 5,000 questions, and they ask them in multiple different ways. So if you don't have it, get it. And if you need the link, message me and I will send you the link to get you exactly to that exam simulator. All right, let's see. How many people do we have in this group? We ain't got a lot of people. What's going on? Where is everybody? Well, it's only been a minute and I've been talking my ears off, talking y'all's ears off. Ugh, that needs more honey. All right, it's called Lab CE, LABCE, or Media Lab. Go on lab, something on my teeth, labce.com. Sorry, I'm like talking to Instagram as I should be live on TikTok too right now. I don't know where my other phone is, but actually no. Yeah, let me get my other phone. Hold on. As I'm in sweatpants and shorts. Let's go live on TikTok too, so everybody from everywhere can. Oh, subject lost. Come back. Hello. All right. So give me one more minute and then I'm gonna get started with this study session. Oh, free study session. And for those of you that are in the actual like free study session, thank you so much for being here. Thank you for being a part of my community. Thank you for supporting me, supporting each other. I'm currently on a break with my job right now, and I'm going to have a lot more time to put towards resources for you guys. I'm coming up with a few cheat sheets that I've actually used. All right, my phone needs to go on Do Not Disturb. Um, where did my Zoom go? Yeah, I'm gonna come up with a lot more cheat sheets for you that I actually like to use. And yeah, let's just get in on this. All right, so I'm gonna share my screen with you guys on the Zoom. Tell me that you can see. Let's get the chat popped up. Oh, damn, there's only 10 people in here. What the helly? Well, hi everyone. So what we're gonna do, I'm popping up Media Lab. I'm gonna do random questions, unless someone wants to do a particular area. Put if you're cool with random questions, just put that in the chat. If not, if you're like, I need to do blood bank, put it in the chat real quick. We'll try to. Hey Nilab, hey Crystal. If you're cool with the regular, okay, Kenya is saying blood bank. I don't see anybody else saying blood bank, but okay, hematology, blood bank, micro, bomba clot. What are we gonna do? All right. We have two hemes, two blood banks. We can do heme and blood bank. Let's just add this to, let's do selected areas, and we'll do heme and blood bank. Why not? We'll stick with 25 because I'm sure that there's going to be a lot of like explanations happening. So let's start this exam simulator here. I gotta move this and start. And let's move this over to here because this isn't normally better. All right, so the first question is identify the nucleated blood cell. Identify the nucleated blood cell. And it looks, to describe to you guys, if you guys are not on the actual Zoom right now, it is like a larger pale blue ground glass cytoplasm, kind of lacy chromatin. What do we think that that is? You guys are saying band? This? We're calling a band? Angelica. Angelica says mono. You have to join my school community. Join the school community. I'm pretty sure the link is in my bio. If not, the link is in my Facebook bio for surely. Yes, we're saying mono. This is definitely a monocyte. And I was trying to describe it to my viewers on TikTok. Yes, on TikTok and Instagram, exactly. So monocytes, it says typically 15 to 20 micrometers in diameter. They have a round, oval, or kidney-shaped nucleus, but frequently have horseshoe-shaped indented nuclei seen in this photograph. If you're not on the Zoom, it's on the Zoom. The chromatin pattern to describe as lacy. It's finer than the other leukocytes normally seen in the peripheral blood. Lacy, kind of like squiggles, right? Not as condensed and dense as like a lymphocyte or a seg or something like that. Um, yeah, that's a big ass giant platelet for surely next to it. And the blue-gray cytoplasm is described as ground glass. That's something big you're going to see on your ASCP exam. Ground glass with lacy chromatin. It's got big old vacuoles. Think monocyte. All right, let's go next. All right. So we have this is hematology disease states erythrocytes. A serum ferritin above what level would be suggestive of iron overload and possibly hereditary hemochromatosis or HH in a premenopausal woman? Now, these questions, so the answer choices is 100 nanograms per milliliter, 200 nanograms per milliliter, 300 nanograms per milliliter, or 400 nanograms per milliliter. This one is going to be straight memorization because there's no good way to remember this, honestly. And if we don't know, like you guys can take a guess. If we don't know, we can take a guess and then we can go further into explaining why. These explanations on Media Lab and Lab CE are great. And if we don't know, I say, and I read this somewhere, it's like the answer is normally B. Yeah, if you have no idea, your best guess is going to be B. It's not C. All right, first, what's the normal value for normal ferritin? That's a great question. I don't even know that one. You know, honestly, the facility that I work for, I we don't do any iron studies, so it's been so long since I've done iron studies. But we can, if you go onto ASCP content outline, you do like a quick search, and then the PDF, if you scroll all the way down. These are calculations, reference ranges. And if it's not here, then we could probably just look it up. I feel like it differs between instrumentation, so that's probably why they don't have it on here. Let's go. All right, everyone's saying 200. We can try 200, which is B, and see what it's talking about. Hey, 200 was right. Okay. So again, if you don't know, the answer is probably B, and B was the correct answer. So a serum ferritin result greater than 200 nanograms per milliliter suggests iron overload and possibly hereditary hemochromatosis in a premenopausal woman. That question difficulty was a level 6. And let's look up what normal ferritin levels are. What is normal reference range for ferritin in premenopausal women? Just so we can clear that up too. This is the reference range. I'm losing it today. The normal reference range for ferritin in a premenopausal woman varies by lab. See, that's what I was saying. But it generally falls between 15 to 205 nanograms per milliliter. Well, that's a big ass freaking range. Crucial to refer to the specific reference range provided by the lab. Results can differ based on age, gender, and other factors. So, I don't even know how we would remember this. All right, hereditary hemochromatosis is also known as iron overload. Serum ferritin, what does ferritin do? Anybody? Remember what ferritin versus transferrin? No one remembers. So,
Sure. Chug that.
um, ferritin versus, yeah. So ferritin, I believe, is the one that stores the iron, and transferrin is the one that moves the iron in the peripheral blood, right? So serum ferritin, let's see. Actually, let's look up the differences so I can explain this better to you guys. Ferritin versus transferrin. Iron studies have always been a difficulty for me. I'm going to be totally honest to you. Ferritin stores iron in the body, primarily in the liver, spleen, and bone marrow. Transferrin transports iron in the bloodstream from the intestines to the cells that need it. So, if it's storing iron, so how exactly is that happening? So it's within those organs, and then transferrin is like in the bloodstream, or is ferritin, sorry. This is how I study, guys. I really go into like the nitty-gritty, like how, what, who, when, where, how, and why, right? So ferritin in serum. Okay. Actually, let's go back to this ferritin versus transferrin. Ferritin in serum or in an organ? Ferritin is a protein that stores iron in your cells. So ferritin, okay, we know that. Okay, Nilab is saying ferritin binds the iron. Right, and then it helps the iron go. It's okay, so it's being stored in, what did it say? Your liver, your spleen, bone marrow, and it's helping incorporate the iron into the red blood, or into the hemoglobin, into the red blood cells. And then transferrin, I'm assuming, is taking it from, like, say, your spleen when it's recycling red blood cells, and then it's transporting that to the liver, bone marrow, things like that. Ferritin binds iron ions and stores them within cells, preventing iron overload and toxicity. Okay, so let's go back to the question. Serum ferritin above what level would be suggestive of iron overload? And we know that a regular that ferritin reference range, women, is between 15 and 150. So I guess this is just gonna have to be straight memorization, y'all. Knowing that 15 to 150 is a regular women reference range of ferritin. If it's over 150, so the first one, um, uh-oh, why does it say, due to the large number of participants in this meeting, system messages for those who have joined or left have been disabled. Okay, cool. So I guess anything over 150 is going to be suggestive of iron overload. Does that kind of make sense? Like how I just went like all over the place for that one? Anybody? Okay. Okay, cool. Because my brain literally goes like 10,000 miles an hour. Neelav's like, I don't know. That one was a hard one. I'm not gonna lie. It was a level 6, but trying to get down to the how why of things is how I study. Because I feel like now, once you go back and you have a question about hereditary hemochromatosis, iron overload, and serum ferritin levels, you're gonna remember Marilyn being like on a fucking rabbit hole talking about 15 to 150. Okay, anything over that, we're thinking iron overload, right? All right, so question number 3. A D negative mother gives birth to a baby that tests as D negative in the immediate spin phase. What step should be performed next? A, calculate the dose for RhoGAM. B, perform a weak D test. C, administer 1 dose of RhoGAM. Or D, perform a Kleihauer-Becky stain. All right, chat, you guys are great. Yes, we're gonna perform a weak D for surely. Right? So we have a D negative or RH negative mom, giving birth to an Rh negative baby, we want to and that's just that immediate spin. We want to make sure that Kenya, why you go like this? We want to make sure that we perform a weak D test. Why? Why is that important that we perform a weak D on an Rh negative baby coming from an Rh negative mom? The reason why is because we want to ensure that that baby is in fact Rh negative. The whole purpose of a weak D test is to see if they're weak D positive. Because if that baby is in fact weak D positive, that means mom could possibly be exposed to those baby cells. And that's no bueno. Okay, mommy? That is not bueno. So, an Rh negative mom giving birth to an Rh negative baby, you have to go through and do a full-on weak D test. What happens is you do 1 drop of the baby cell, 1 drop of the anti-D antisera, and then you do a saline control or a monoclonal control. You incubate for 15 minutes at 37 degrees, right? To allow that antibody to bind to any antigen, okay? Bind to any antigen, any D antigen that might be on the outside of that baby's red blood cells. So if the baby maybe is like a partial D or a mosaic or something weird, and they only have a little bit of that Rh positive or the D antigen, doing a weak D is going to ensure that we can detect it. So now, say mom gave birth to that baby, it only takes less than zero point 0.1 mLs of can you explain partial D? I'll come right back to that. Um, it takes less than zero point 0.1 mLs of Rh positive cells for a mom or an Rh positive or an Rh negative person to develop anti-D. So less than zero point 0.1 mLs of Rh positive blood can spark someone's immune system to produce anti-D. So it's very important that we know what if the baby is truly Rh negative or if they're weak D positive. Partial D, let's look it up. Partial D. Oh, I put partial D, yeah. Blood bank guy. We're gonna go straight to blood bank guy because this man is the Jesus of blood banking. Okay. All right. So it says the main Rh antigen we know is the D antigen. The gene known as RHD on chromosome 1 codes for this large transmembrane protein. It is present in the majority of most people, regardless of race, right? I think it's like 85% of the population is Rh positive. All right. No, 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 no. Okay. So, if those substances change the appearance or structure of exposed parts of the antigen on the outside of the red blood cells or epitopes of this D antigen, the patient is described as having a partial D. If someone with a partial D is given blood from someone with a normal D, he or she or they may make an antibody against the portions of the antigen that he or she or they lacks. So the resultant antibody looks like an anti-D because it reacts against all normal D positive cells. So pretty much if you're a partial D, you might have this D antigen, right? This is my D antigen. But you might have one that kind of goes like this instead of like this, right? It kind of looks like a regular D. Maybe in our testing, you put the drops of anti-D in there and you're like, boom, this person's Rh positive. They get a transfusion. 2 weeks later, they come back. Holy shit, they have an anti-D. What the hell happened? You send it out for a genotype to your reference lab, and then boom, they're a partial D because their D antigen is not that of a normal D antigen. It might have portions that it's lacking portions of that D antigen. Does that make sense? Does that make more sense to you? Crystal? Okay, be it. Okay, be it. All right, next. What best describes the cells seen in this illustration? Well, I can't say it. I mean, shit. All right, so A is ovalocytes, B is Burr cells, C is sickle cells, and D is elliptocytes. We are saying B for Burr cells. I can agree with that. Yes, Burr cells, also known as echinocytes, may occur as an artifact. What is an artifact? Probably, you just swiped too hard, or the pressure was too hard, or the instrument just did it too hard, whatever. Or in the cases of heart disease, uremia, bleeding ulcers, stomach cancer, Burr cells have uniformly shaped pointed projections on the outer edge of the cell. Ovalocytes also, less known as megalocytes. I've never heard that. Ovalocytes have an oval or egg-like shape. They are similar to elliptocytes but have a fuller appearance. Ovalocytes are seen in vitamin B12 and folate deficiencies. Sickle cells or drepanocytes resemble a crescent. One end must be pointed. Sickle cells are associated with sickle cell anemia. Elliptocytes are rod, cigar, or sausage shaped. Elliptocytes are associated with hereditary elliptocytosis, hemoglobin C disease, pernicious anemia, sickle cell trait, and thalassemia. It's a good one. All right, identify the nucleated blood cell that is indicated by the arrow. So this one is the nucleus is about the size of a red blood cell. It's got scant cytoplasm. It's got dense chromatin. Everyone is saying A for lymphocyte. And I can agree with that. Lymphocytes are non-granular white cells with a large dark staining nucleus, very little cytoplasm, which stains light blue. They are the smallest white cells by size, typically second most numerous after neutrophils. Right, and that was a level one. That was an easy one. Okay, come on now, give us a hard one. In the Coombs phase of a cross-match, what is the proper procedure to follow if the check cells give a negative reaction? A, repeat the procedure with new AHG reagent and check the cell washer. B, add additional check cells and dilute with 100% distilled water. C, add additional AHG reagent plus proteolytic enzymes to enhance the reaction. Or D, accept the cross-match results as correct. Nothing further needs to be done. Well, okay, repeating the question. In the Coombs phase of a cross-match, what is the proper procedure to follow if the check cells give a negative reaction? Okay, so if check cells, the purpose of the check cells is to make sure that we added that AHG reaction and that the reaction that you're getting at the AHG phase is truly negative, right? So we have your immediate spin phase, then you incubate it with your enhancement media, your LIS, your PEG or saline. Then you spin it, you read it, then you wash it. Then you're going to put 2 drops of AHG or anti-human globulin. What is anti-human globulin? It is an antisera with IgG, anti-IgG antibodies in there, right? So they're going to bind to whatever antibodies are coating the red cells, right? So if the check cells are negative, I'm not accepting my results as okay, nothing further needs to be done. No, no, no. I need to repeat it for sure because I fucked up somewhere. Adding additional check cells is not going to change anything. Diluting it with 100% distilled water is not going to do anything. Adding additional reagent plus a proteolytic enzyme to enhance the reaction is also not going to do anything. Okay? Something's going on with either the reagent or something. Me personally, I think the answer is A. Let's see. Okay, answer is A, correct. And that was a level 3. So what Lab CE says is the check cells are added when a negative result is obtained at the Coombs phase of testing to ensure that the AHG reagent was added and not neutralized. The addition of check cells following a negative the addition of check cells following a negative result at the Coombs phase should yield a positive result. If the check cells are negative, then the procedure must be repeated with the new AHG reagent to ensure that the reagent is working properly. It is also recommended to check the cell washer to ensure that the cell buttons are not being under or overwashed. Adding additional check cells with 100% distilled water would hemolyze the cells in the tube. Okay. Proteolytic enzymes are used as an enhancement reagent to the reagent red blood cells for antibody detection and identification. They're not used in compatibility testing. So a negative result at the Coombs phase of compatibility testing is an invalid result, and it must be resolved before transfusing the patient with that product, right? Does that make sense? I don't really like this question, to be honest with you, because like I typically am like, all right, I probably fucked something up. It's probably not the cell washer. You should be doing weekly maintenance on your cell washer. You should be doing quarterly maintenance on your cell washer, and you should be having semi-annual and annual PMs on your cell washer if your biomed department is good, unlike mine. So, and I don't know that I would repeat with the new AHG reagent, to be honest with you. I think they're thinking like go above and beyond, repeat with a new reagent, but you need to do QC on that too, right? You'd want to make sure that the QC was done for the day. If the QC was good, maybe it's not the reagent, but hey, maybe I might open another bottle and see what happens. Okay? Does that make sense to everybody? Hopefully. Okay, bet. What is the purpose of adding citrate to donated red cell units? A, it stabilizes the pH of the unit during storage. B, it is a substrate in ATP synthesis. C, it supports ATP generation by the glycolytic pathway. And D, it prevents coagulation. So, what's the purpose of adding citrate to donated red cell units? Does it have to do with pH, ATP synthesis, supporting ATP generation, or preventing coagulation? All right, we have a lot of D's in the chat. We can go D. Hey, that is what I'm talking about, mother truckers. Citrate chelates calcium. Okay, what does that mean to chelate calcium? It's going to bind. I'm going from TikTok to Instagram here. It's binding the calcium, right? And thus preventing coagulation in the red cell unit. It also stabilizes the red cell membrane. Okay, I'm kind of smart here. Sodium biphosphate is added to stabilize the pH of the unit during storage. And then adenine functions as a substrate for ATP synthesis in the red cells. And dextrose helps in ATP generation by the glycolytic pathway. That was a level 5 question. Okay, level 5. That was a good one. So remember, citrate in like our light blue top tubes. Sodium citrate is chelating the calcium, preventing coagulation from happening. When you add back the calcium when you're doing your coagulation studies, right? It's not as strong as like ETA, so the coagulation pathway can happen. C for citrate, C for coagulation. Yes, that's a good one, Elab. All right, what's next? So I'm drinking down my tea. The average bone marrow cellularity in a normal adult 50 years old is 30, 50, 65, or 70. The average bone marrow cellularity in a normal adult 50 years old is 30, 50, 65, or 70. All right, we got a lot of B's in the chat. B's in the chat. All right, that is what's up. B is correct. The overall bone marrow cellularity is estimated. Oh, is that me? Who did that? Okay. Is someone like doing something on my screen? How do I get that off? That's crazy. Okay. The overall bone marrow cellularity is estimated by comparing the amount of hematopoietic tissue with adipose or fat tissue. And an easy way to calculate it is to subtract the age from 100 and adds plus or minus 10. So in this example, 100 minus 50 is 50. So the normal bone marrow cellularity is between 40 and 60. 30 as a result is too low, so A would be incorrect. And then 65 and 70 are too high. And that was a level 5 question. All right, number 9. All of the following would be included in a hemolytic transfusion reaction investigation except what? A, ABRH check of post-transfusion sample. B, leukocyte antigen studies. C, direct antiglobulin test or a DAT on the post-transfusion sample. Or D, a clerical check. What would not, all of the following would be included in a hemolytic transfusion reaction investigation except what? ABRH, leukocyte antigen studies, a DAT, or a clerical check. All right, we got B's in the chat. We have one C. We're going B. Yes, leukocyte antigen studies for sure. The correct answer is leukocyte antigen studies. We would not perform that on a hemolytic transfusion reaction investigation. Something that's a hemolytic, it's okay, Kenya. You're good. You're good. This is the time to learn. Seriously, mess up all you want. This is our time to learn. We want to do an ABRH check of the post-transfusion sample. Normally, in any transfusion reaction investigation, first things first that happens is the nurse is going to be like, I think my patient's having a transfusion reaction. What do I do? Or they're going to be like, the doctor said that the patient had hives and itching. And you know what I'm saying? Y'all know. Everybody here knows what the nurses be saying, okay? They don't know what the hell is going on. Just be like, yes, stop the transfusion, slap them with some Benadryl, send the unit and all of the attachments down to the lab. I need you to draw a post-transfusion sample. What does that mean? Draw me another pink top, my love. Put 2 initials or 2 signatures, however y'all do it at your facility. We need date, time, and initials, okay? It needs to be blood bank certified. What we are going to do on the blood bank side, we're going to grab that pre-transfusion sample. We're going to do ABRH on both of them. We're going to do a DAT. We definitely do a DAT on the post-transfusion sample. Some facilities do have you do a DAT on the pre-transfusion sample. And we're also going to do a clerical check. What is a clerical check? Not with the Filipino accent. A clerical check is we're going to go down the list of name, date of birth, medical record, type, DIN number, product number, expiration. We are going to go down the whole thing and make sure that we have the right patient at the right time, at the right date, give them the right product, right? All of that goes to say that in a hemolytic transfusion reaction investigation, I just went on a whole tangent about transfusion reactions, but in a hemolytic transfusion reaction, it's most likely due to an ABO incompatibility. So we're definitely going to do an ABORH check, we're going to do a DAT, and we're going to do a clerical check. Leukocyte antigen studies, that's normally like if you have a trolley, right? Leukocyte antigen studies are generally performed when investigating a transfusion-related acute lung injury, and those are scary. All right, xanthochromic CSF means that the color of the CSF can be any of the following except what? Pale orange, pale pink, yellow, or blue. If I saw blue CSF, I would stop what I'm doing and I would walk down to the emergency room and see what's going on with that patient. Because what? Okay. Yes. All right. So color can be seen. Xanthochromic, we're talking about a difference of color, right? Xantho, I don't know what the prefix xantho in medical terminology. Let's see. Means yellow. Okay. Means yellow. But the varying, oh, what the hell? The varying degrees of xanthochromia with regard to CSF could be pale orange, pale pink, or yellow. So color can be seen in centrifuge cerebral spinal fluid or CSF specimens and is generally due to the presence of hemoglobin from lysed red blood cells. Therefore, a blue color would not be produced from released hemoglobin, but rather shades of pink and yellow. Pale orange and pale pink colors can be seen from 2 to 12 hours after a subarachnoid hemorrhage. So the color should always be reported, and the specimen could appear yellowish about 12 to 24 hours after such a hemorrhage and should also be noted. Okay, yeah, we said that. However, other conditions, as well as a delay in processing, can lead to false positives. I don't know that I've ever seen that, other conditions and delays in processing. We're not going to blame the lab here, lab CE. It's normally due to a subarachnoid hemorrhage or a very traumatic tap. And that was a level 5. Good stuff. Except, oh, it's okay. That's all right, Nilab. Which of the following group B antigens is generally associated with a mixed field reaction? B, B3, BM, or BX? This is an SBB question. I'm gonna let y'all know right now. This is an SBB question. This is not an ASCP question. But what do we got? We got 2 C's in the chat. Ebony says, I have no clue. SBB is specialist in blood banking. The specialist in blood banking exam. And I think I might sit for that exam by the end of the year just to say that I did it. But those people who have their SBB are the people that know like the technical manual literally from start to finish, like could probably like they like you know how like Jehovah's Witnesses really know the Bible, SBB people really know the technical manual. All right. All right, let's just go see and see what it's talking about. All right, hey, Kayla and Michelle, look at y'all with the B3. Okay, so B3 was actually the answer, although we selected BM. B3 is a group B antigen that is generally associated with a mixed field reaction. Why? It is characterized by a weaker than usual reaction with anti-B and by a mixed field reaction with the same reagent. B is characterized by a strong reaction with anti-B, and then BM and BX are characterized by weaker than usual with anti-B, but no mixed field. So let's look up why. Does anybody know why B3 gives you a mixed? Why does B3 blood group give mixed field reactions? Because what the helly, okay? Let's see what we're talking about. All right, so weak expression of that B antigen due to a genetic mutation leading to a mixed agglutination pattern when tested with anti-B or anti-AB antibodies. Okay, yeah, that makes sense. Okay, so what exactly is happening? They have a genetic mutation in their B allele. Aberrant splicing. This mutation can cause errors in the splicing of the B's gene, preventing the production of a fully functional B protein. Okay, that makes sense. So that's why it would be mixed field because it's not showing the full expression of the B antigen. Bonus points. What is the B antigen? What is the terminal sugar of a B antigen? Somebody tell me. Or tell me the A antigen. Tell me the A antigen and the B antigen. I love this question. And fun fact, I actually have the A antigen tattooed on me. Anybody? Nobody on TikTok, nobody on Instagram. God damn. All right, so A is N-acetylgalactosamine, right? N-acetylgalactosamine, that is the A antigen. And then B is galactose, I'm pretty sure. Let me just triple check myself. B antigen, terminal sugar is galactose. Yes, D-galactose. Hell yeah. Right? And then if I'm thinking about the acquired B phenomena, right? This is going to be a question on your ASCP exam. What is the acquired B antigen? Because it's mimicking galactose, but it's not galactose, it's galactosamine, right? All right, let's go next. Which of the following inclusions marked by the arrow is seen on this smear made with a supravital stain? A. Dole bodies, B. Heinz bodies, C. May-Hegelen anomaly, or D. reticulocytes? All right, we got a lot of B's in the chat. Heinz bodies. Okay, yeah. Because Heinz bodies are red cell inclusions, right? Dole bodies. Okay, let's just read it. Heinz body is correct because Heinz bodies occur as a result of denaturation, and precipitation of hemoglobin and appears round, dark blue, purple granules, often attached to the red blood cell membrane, right? So it kind of looks like little like nipples on the outside of red blood cells. That's how I think of Heinz bodies. Little nipples on the outside. Okay? You're never gonna forget it, Emily. I'm telling you, you're never gonna forget it now. Okay, so they require staining with a supervital stain such as new methylene blue to be visible. Heinz bodies can be seen in unstable hemoglobin disorders or during a hemolytic episode in G6PD deficiency. On a right stain smear, Dole bodies appear as blue-gray inclusions mainly seen in the cytoplasm of neutrophils, right? Dole bodies are in white blood cells, in neutrophils. They are composed of aggregates of rough endoplasmic reticulum. Dull bodies can be seen in a bacterial infection, sepsis, burn in cancer patients, and in pregnancy. Ooh, interesting. May-Hegelen. May-Hegelen. May I say May-Hegelen? Because there's two G's. I'm like Hegelen. Hegelen. Anomaly is a platelet disorder characterized by variable thrombocytopenia, giant platelets, and large inclusions that resemble Dole bodies, called Dole body-like inclusions. And then these blue are ASCP questions of a similar format? Yes, absolutely. Some of my students actually said that some of the study questions that they've gotten off of Lab CE and Media Lab were the exact questions that they got on the ASCP exam, if not incredibly similar. So these blue-gray inclusions are typically larger and rounder than true Dole bodies. They can be seen in neutrophils, eosinophils, basophils, monocytes, and then reticulocytes. We know that they're immature red blood cells. They don't have inclusions. Did I just get lipstick on my nose? All right, so what are the possible ABO genotypes of offspring of parents whose genotype is AA and BB? A, AB, B, AO, C, BO, or D, OO? Hell yeah. Man, you guys are good. And this was a level one. This is very, very simple one. Throw up a Punnett square, AA for the mom, BB for the dad, AB, 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 AB. Do your Punnett square. Period. All right, identify this nucleated red blood cell. Easy one. Again, dense chromatin, nucleus about the size of a red blood cell, scant cytoplasm, pale bluish grayish cytoplasm. We're all saying lymphocyte. I concur. Right? Normal resting lymphs are described as small mononuclear cells with high nucleus to cytoplasmic ratio, scant blue cytoplasm. They are easily differentiated from neutrophils in bands, the last stage of neutrophil development, by the color of the cytoplasm as well as the shape of the neutrophil, right? That was a level 5. Bull crap. That was easy, guys. Come on now. If you don't know your cells going into the ASCP exam, I don't know what to tell you. I don't know what to tell you. Honestly, work on it, okay? How many places, if you're in your rotation, if you're not in your rotation, if you're on my page, dude, I show you on my page the different cells. Memorize it. Commit, take a photograph with your eyes. Do not forget it. All right, so which of the following best describes myelodysplastic syndromes? A myeloproliferative disorder. B, an acute leukemia that is in remission. C, a leukemia that typically progresses to thrombocytopenia and leukocytic anemia. Or D, a qualitative disorder of erythroid, myeloid, and or megakaryocytic cell series. All right, we're getting a lot of A's, a myeloproliferative disorder. Let's see what we're talking about. Myelodysplastic syndromes, we're saying a myeloproliferative disorder. Okay, so I would have gone with D as well. In myelodysplastic syndromes, right? So it says qualitative disorder of erythroid, myeloid, and or megakaryocytic cell series. When I think of MDS, I think of the most colorful slide ever. Reason why is because you're gonna see NRBCs, bands, metas, mylos, pros, immature EOs, all types of shit all over your slide. Horrible for the patient, but absolutely beautiful to see on the slide. I'm not going to lie. In myelodysplastic syndromes, the bone marrow stem cells cannot effectively make erythroid, myeloid, or megakaryocytic cells due to a qualitative or quantitative defect. All syndromes can lead to AML or acute myelogenous leukemia. A myeloproliferative disorder, they're characterized by an excess proliferation of one or more cell types in the bone marrow. And then acute leukemia that is in remission does not have leukemic cells present, right? One would only see normal cells once a patient is in remission, or you'd hope that if they're in remission, that they're not going to have any leukemia or any leukemic cells in their peripheral smear. Chronic lymphocytic leukemia, right, or CLL is an example of leukemia that progresses to thrombocytopenia and lymphocytic leukemia. CLL typically has lymph node involvement and characteristic smudge cells on the peripheral blood smear from the fragile lymphocytes present. All right, and that was a level 5 difficulty. So we have to remember a myelodysplastic syndrome, not about a myeloproliferative disorder. Like it's not excess proliferation of one thing. It's that your bone marrow, either qualitatively or quantitatively, cannot produce proper erythroid series, myeloid series, or megakaryocytic cell series cells. Okay? Try to remember that. All right, what's next? Platelet products will be prepared from a whole blood donation. What must be used to prevent potential contamination of the platelets with skin cells and bacteria? A diversion pouch, B, 70% isopropyl alcohol, C, attached segments, or D, irradiation. Ooh, we got a lot here. We got a lot here. What time is it? 3:43. I'm looking. Okay, we got D, A, D, B, A, B, D, 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 D. All right, so one more time. Platelet products will be prepared from a whole blood donation. What must be used to prevent potential contamination of the platelets with skin cells and bacteria? A diversion pouch. B, 70% isopropyl alcohol. Okay, Xavier. C, attached segments, or D, irradiation. All right, what's our final answer? God damn, everybody's confused. So I'm thinking skin cells and bacteria, you would think that you would just, you'd be using isopropyl alcohol to clean before you puncture someone's skin, right? Attached segments. What two can we immediately eliminate? A and C for sure. Segments and diversion pouch, no. I'm sure A is correct. Yeah, diversion pouch. Is that true? Do we think A? Irradiation, we want that's to prevent graft versus host disease. All right, are we going with A or B? Because we're having a lot of All right, let's go B and see what it's talking about. Oh my God, Nilab! It was A. Okay. So good job to those who clicked diversion pouch. Okay, so diversion pouch is used to physically capture and hold the initial blood collected in a blood donation since the initial blood contains epidermal skin cells and any bacteria present. Okay, me personally, I'm going to be completely honest with you. I've never heard of a diversion pouch. But let's look at what is a diversion pouch for blood donation? I'm a visual learner. Okay, let's move the chat over. I saw it in a blood donation center. Damn, Nilab. All right, let's click this one. Snap closure. Okay, donor needle, phlebotomist protection advice. Okay, sample diversion pouch, sample needle assembly with vacuum tube holder and lid. All right, let's click this one. Phlebotomy needle, blood diversion pouch is this little guy here. Can y'all see that on the Zoom? This little guy, adapter to allow transfer of blood from the diversion pouch into vacutainers, creating specimens for lab testing. Bomba clot! All right, so now we know that a diversion pouch, so probably what they do when you first donate blood is they have that clamped off from the multiple bags and they put it into this diversion pouch and then all that yucky blood right there. What level was this question? That's a great question. That was level 5. Zam. Yeah, they use it to collect blood from that pouch um, to go to go to the lab, right? That's the tubes that are used for the lab. And then 70% isopropyl alcohol is not a sufficient antiseptic for skin during blood donation. That's true. That is true. I should have known that. You use like an iodine or a chloramphenicol prep. Attached segments allow pre-transfusion testing to occur. Yep, we know that. And then irradiation is used to prevent donor T lymphocytes from multiplying and causing transfusion-associated graft versus host disease. It's not used to prevent contamination. Good job, Nilab and whoever else said diversion pouch, because I didn't know that one, and I'm a blood banker. You are working in a hematology laboratory, and the machine flags an outlier result for a 51-year-old male. The blood was collected in an EDTA tube for a CBC. The hematocrit of the specimen is high at 60%. Which of the following would you do? A, collect the blood again, but use less sodium citrate in the tube. B, collect the blood in heparin. C, report the results. Or D, assume that the specimen was switched with that of a newborn child. I'm going with D. Let's just assume, okay? Let's just say F CLIA, F JCO, F Joint Commission, F CAP, F. Let's just assume in the laboratory. Okay, so hematocrit. Okay, I'm going to read it again. You are working in heme, and the machine flags it's a 51-year-old male as your patient. Blood was collected in an EDTA tube for a CBC. Cool. The hematocrit of the specimen is high at 60%. What would you do? Collect it again, but use less sodium citrate in the tube. B, collect the blood in heparin. D, report the results, or assume that the specimen was switched with that of a newborn child. Okay, so we're not we're not going to assume that the specimen was switched with that of a newborn child for sure. So D, we're going to get rid of. Um, we're saying A. Everyone's saying A, C, B. Okay, so collect the blood again, but use less sodium citrate in the tube. We didn't use sodium citrate at all. So I don't know where they're getting that from. So I would eliminate A. Um, B, collected in heparin. I don't know what that would, that's not an appropriate tube for whatchamacallit. And then report the results. I mean, yeah, as long as everything else makes sense, I might report it. Like if that's a normal thing for him, because some people just have a high crit. What are we saying? C? Let's see what C is talking about. Hey, C was the correct answer. Okay. We're going to report those results. 51-year-old male got flagged on the instrument. It was collected in the proper tube. Crit is at a 60%. What would you do? You're going to report it, okay? There may be several reasons we don't use heparin and citrate for CBC. It should be an EDTA for sure. Yeah, for sure. An EDTA, it has to be, well, at least in the United States, in the places that I've worked, it's always in an EDTA tube, okay? There may be several reasons for a high crit, including the obvious possibility that this is a newborn, normal range of 55 to 68%. Another likely reason for a high crit is dehydration. The individual happens to have less fluid. Yes, yes, less fluid in the body. Less frequent causes include polycythemia vera or high hematocrit due to blood doping. Oh, wow. I mean, maybe he's a 51-year-old male that does marathons or something and he's taking like EPO or something. The first choice, collect the blood again and use less sodium citrate, is wrong for two reasons. You use EDTA rather than sodium citrate for a CBC. And then number two, blood collection is a standardized practice, and that's your goal in testing the hematocrit is to determine the actual hematocrit, not to artificially disturb the ratio of anticoagulant to arrive at a normalized determination of the hematocrit, right? We don't want to try to change up people's results. Is it possible that the draw was QNS? Maybe. But maybe. I mean, you'd have to look at the sample, but it's not giving us any insight to that, right? Sometimes the results are absolutely astronomical with a sample that the quantity is not sufficient. Xavier, please get your cat balls out the screen. Oh. Okay. While it is true that okay, wait, the second choice, collect blood in heparin, is wrong because you don't collect CBC specimens in heparin, you use EDTA, right? While it is true that this hematocrit falls within the normal range of a newborn, 60% is not so tremendously high. Normal hematocrit for an adult male is 42 to 52. That you ought to assume that specimens have been switched. Okay. It's not so tremendously high that you ought to assume that the specimens had to have been switched. Yeah, definitely not. It's not that high. And that was a level 5. Oh, and if you don't know, this is Xavier Ezra, my 1.5-year-old child. All right, this is question 18. What is the principle of the new methylene blue test? A, reflecting ultraviolet light. B, inhibit lipids and proteins. C, staining hemoglobin components. Or D, staining cytoplasmic RNA, mitochondria, and ribosomes. New methylene blue. What is the principle of the test? Reflecting ultraviolet light, inhibiting lipids and proteins, staining hemoglobin components, or staining cytoplasmic RNA, mitochondria, and ribosomes. All right, we're getting a lot of D's in the chat. D's in the chat. That is correcto, okay? New methylene blue. It's a supravital stain used for reticulocyte count. What does supravital mean? Anybody? Supra vital. You know, my hair is hairing today. Okay, I don't know what's going on with this lock. It's hella long. But the hair is hairing today. Supra vital. What does it mean? Prefix not supra. Above or over. Supravital definition. I'm going to get you guys the exact definition, if I could spell definition. Supravital refers to living cells that have been removed from an organism and stained with a dye, allowing them to be studied under a microscope. Makes sense? So we're staining cytoplasmic RNA, mitochondria, and ribosomes. It does not stain hemoglobin components, it does not inhibit lipids and proteins, and it does not reflect UV light. And that was level 3. Bet. Proteolytic enzyme techniques may be useful in identifying which of the following antigen groups: Kell system, KID system, MNS system, or Duffy. Proteolytic enzyme techniques may be useful in identifying which of the following antigen groups: Kell, KID, MNS, or Duffy. We're getting a lot of, let's see. We got B, A, C, D. I forgot A. Not D for sure. Okay, so proteolytic enzymes, say we're doing like an enzyme treated panel. Enzyme treated panel destroys what specifically? And enhances what else? Destroys Duffy, enhances RH and Kel, I'm pretty sure. Let's go on Blood Bank Guide and just double check because he's got a good one. He's got a, oh man, I have a lot of tabs open here. Um, Proteolytic enzymes in blood bank. Enzymes. All right. So enhanced ABOR, well, ABO related or ABOH, the RH system in KID. Decreased is the MNS in the Duffy system. Unaffected is Kel, but destroyed is the Duffy, right? No, 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 no. Okay, what does it say? Changes. Duffy dies, Kel lives. It's a good one. All right, so back to the question. Proteolytic enzyme techniques may be useful in identifying which of the following antigen groups, Kel, KID, MNS, or Duffy. You know, this is an interesting one because I guess it depends, right? Are you ruling in something or ruling out something? Because sometimes I'll like say I have a Duffy A and an E, and there's like only two cells that have E, right? But both of those two cells are positive for Duffy A, so I would do an enzyme treated panel to get rid of the Duffys and then have that E be able to, the anti-E be able to express, right? So I don't know, dude. We can take a guess and then see what the explanation is behind this. Everyone's saying B. All right, let's see what it's talking about. All right, so the reactivity of KID antibodies is enhanced by the use of proteolytic enzymes. Okay, so I guess it's talking about what is being enhanced when it asks you what is it's helpful in identifying which of the following antigen groups, KID antibodies. Xavier, I mean Zion, stop. Antibodies to KID antigens are difficult to detect because they show dosage and may not react well with heterozygous cells. KID antigens can quickly fall to non-detectable levels in vivo and sometimes require complement to react in vitro, thus losing reactivity during storage of serum. Okay. This was a level 5. The use of proteolytic enzymes is known to enhance antibody reactivity for KID, RH1 Lewis, and the I antigens. On the other hand, proteolytic enzymes are known to destroy or decrease reactivity to Duffy and MNS. Cal antigens are not affected by conventional proteolytic enzyme method treatments. Okay, so for this one, we would just need to know KID is enhanced. Back to this one. Yeah, RH and KID are enhanced. Kel is unaffected. Duffy is destroyed. So, and then MNS, what did it say? MNS is what? MNS is decreased. So if we wanted to identify one of these antigen groups, KID would be your best answer. Does that make sense to everybody? Everybody trying to be a guest in my live. What the hell? All right. Enzyme treated panels. Yeah, it is really confusing to be honest with you because it's like how does it enhance something or destroy something or whatever. So if we think of a proteolytic enzyme, what is it doing? It's chopping something. It's slicing something. It's destroying something, an enzyme, right? Or proteolytic. I think the suffix lytic means to like cut, right? Proteolytic enzyme definition. Let's get you the exact definition. Okay, they're enzymes, also known as proteases. They're enzymes that break down proteins into smaller peptides or amino acids. So, proteolytic enzyme in blood bank, just to give you like more of an understanding, it's a protein degrading enzyme such as physin or papain or whatever, used to modify the surface of red blood cells to enhance antibody identification by altering the expression of RBC antigens, right? So when we say that Duffy is destroyed, that means that the enzyme is degrading the protein structure of Duffy. So if I have an anti-Duffy A or a Duffy B, it's not going to be able to attach to the Duffy antigen on those reagent red blood cells because I'm destroying it by treating those red cells with physin, papain, um, what are the other ones? Bromelain. You know what I'm saying? Does that kind of make sense? Who is it? Kenya? Does that kind of make a little bit more sense? So the enzymes are doing something to degrade the protein structure of that antigen. All right, back to the exam simulator. Bone marrow examination may be used to aid in the diagnosis of which of the following? A, iron deficiency anemia, B, leukemia, C, infectious mononucleosis, or D, plasma cell neoplasms. Bone marrow examination is used to aid in the diagnosis of which of the following? Iron deficiency anemia, leukemia, infectious mono, or plasma cell neoplasms. So would you go as far as doing a bone marrow biopsy on someone with iron deficiency anemia? Absolutely not. Why would I need to do that when I can do ferritin, TIBC, transferrin, iron, a CBC, retic count? I don't need to do a bone marrow biopsy. Same thing with mono. Mono, swab my shit and see if I have mono. Give me a CBC and see what my lymphocytes look like. Okay? So I wouldn't do a bone marrow for iron deficiency anemia or mononucleosis. Now we're in between leukemia and plasma cell neoplasms. All right, we're getting a lot of C's. I mean, sorry, B and D. All right, which one do we think? B for leukemia or D for plasma cell neoplasms? B. All right, let's go for it. Excuse me. All right, so leukemia is your correct answer. Oh, you have litter on your nose, girl. This is my daughter, Zion Elise. This is the other one. All right, so, oh no, you smell, girl. Mm-mm. Nasty. Okay, so leukemia is your correct answer. Reason why is because a peripheral blood examination is the first step in assessing a blood marrow evaluation because peripheral blood cells usually reflect the bone marrow status. So for iron deficiency anemia, iron studies are the key to diagnosis, not a bone marrow biopsy. Infectious mono is normally a self-limiting lymphoproliferative disease caused by Epstein-Barr, and then the presence of various forms of reactive lymphocytes is key to diagnosis along with serological testing to detect the presence of heterophile antibodies. That's why I was saying swab my shit and do the little, what is it called, agglutination test. Plasma cell myeloma usually secretes monoclonal immunoglobulin into the serum and/or urine. Serum and/or urine electrophoresis reveal increased protein with a narrow range of electrophoretic mobility, or an M spike. Let's remember that, an M spike in plasma cell myeloma, multiple myeloma. Immunofixation will determine the class of immunoglobulin. Plasma cell myelomas have clinical presentations varying from asymptomatic to aggressive. It is therefore important to recognize symptomatic plasma cell myeloma that shows symptoms of hypercalcemia, renal insufficiency, anemia, lytic bone marrow, leading to bone fractures and other organ involvement in asymptomatic plasma cell. This is a lot of stuff on plasma cell, but pretty much leukemia, you have a leukemia, you're most likely going to need a bone marrow biopsy, period. All right, let's go next. Essential components of compatibility testing include all of the following except what? Antibody screen on recipient serum. B, major crossmatch or computer crossmatch. C, ABO and RH typing of a recipient. And then D, a DAT, or direct antiglobulin test. So essential components of compatibility testing include all of the following except which one? Which one do we not do for compatibility? An antibody screen on the recipient serum, a major crossmatch or like an AHG crossmatch or a computer crossmatch, an ABO and RH typing of the recipient, or a DAT. What has nothing to do with compatibility testing? TikTok going off over here. TikTok talking about DAT. Yes. Right, so DAT is used to detect the in vivo sensitization of red blood cells with IgG or complement components. So DAT has nothing to do with me testing compatibility. Now, aside from that, if I do have a positive DAT, right? Let's say patient is A positive with a positive antibody screen and they have a positive DAT. We need to resolve that DAT before we can transfuse compatible red cells, right? Or at least we'd like to resolve that DAT. If it has IgG bound to the outside of the red blood cells, say we're doing polyspecific AHG DAT, it's positive, then we split it up. We're doing IgG, we're doing C3. C3 is negative, IgG is positive. What do we do? What test do we do? What do we do if we have a positive DAT IgG? An elution, correct, Aldo. We do an elution. What are we doing with an elution? What is the whole premises of an elution? Anybody? Yeah, positive DAT needs you mean an elution. Exactly. So the whole premises of it is we're eluting, we're taking off the antibody that's coating the red blood cells and seeing what the identity of it is, right? So we do the whole elution process, then we have our little blue eluate, and then we're going to test that against a panel or your screening cells to figure out do not leave it to figure out the identity of that antibody that's coating the red cells and causing that positive DAT. Now, in regular compatibility testing, we don't do a DAT test. We need to do a type, a screen, and a cross match, period. Type, screen is negative. We can do a computer cross match or electronic cross match. Type, screen is positive. We need to do an antibody identification. Some places make you do a a DAT or an autocontrol. Make sure that's negative. Figure out your antibody. Do an AHG cross match with compatible antigen negative blood. Boom, you're good to go. All right, and that was a level 3 question. All right, let's see what we're talking about here. Oh, TikTok is making me verify myself. Okay, 22. Washing red cells may be performed to remove what from the unit? White blood cells, platelets, plasma, or proteins? Washing red cells may be performed to remove what from the unit? Washing white blood cells away, platelets away, plasma away, or proteins? All right, we got a lot of D's in the chat. Yes. Proteins. Washing. This is a level 5 question. Washing red blood cells may remove some white blood cells, but it's not an efficient way to do so. Irradiation of the unit is the best approach when removing white blood cells. Also, everything in the United States, and I think Canada too, is leukoreduced. We have great leukoreduction filters in this country, in first world countries, I guess you could say. So already significantly reducing the amount of leukocytes that are transferred from the donor to the recipient. But irradiation ensures that we're getting rid of all the white blood cells, or at least making them not able to do their thing. During collection, the whole blood unit undergoes a light spin to separate the red blood cells from the plasma and the platelets. Platelet-rich plasma is diverted to another unit for processing. There are some residual plasma in the red cell unit, but not enough to cause a reaction. But washing is going to remove the remaining plasma proteins that are present in the unit. We'd want to wash. Sometimes people have weird reactions. We gotta eliminate that. Washing might be your best answer, especially with the kiddos. All right, this one. Which of the following gene translocations is associated with acute promyelocytic leukemia, or APL? If this is not a level 9 question, I don't know what the hell is, because I don't know. The only one that I'm familiar with is T911. So A is T821, B is T1517, C is T911, and D is T69. I couldn't tell you. I hate these questions too, Aldo. Honestly, this is some booty. All right, so we got a B, 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 D, A. I know, I have no idea too. Okay, TikTok, we're getting a lot of 15, 17, so B. All right, let's see what B talking about. Hey, TikTok for the win, and whoever said B over here. All right, so acute promyelocytic leukemia, or APL, is known by WHO, or the World Health Organization, classification as acute myelocytic leukemia, AML, with a T, or what is it called? Translocation 15, 17, or a Q22, Q12 is the correct answer. All those numbers and shit. This is a level 5. Bullshit. That's crap. This couldn't be a level 5. First of all, I'm a medical laboratory scientist. I'm not a doctor. I didn't sign up to be a doctor. If I wanted to be a doctor and know these things, I would have went to medical school. I would have went to a pathology residency. I would have went for a heme pathology residency. I mean, fellowship. Okay? I don't know none of these things, but TikTok, good for you guys knowing this stuff. And yeah, this is definitely like a level 10 for me. All right, so 821 is associated with AML, previously known as AML with maturation. C is T911, associated with AML with monoblasts and pro-monocytes predominant in the peripheral blood. T69 is associated with AML with or without monocytic features. It is associated with basophilia and multilineage dysplasia. Y'all don't even worry about that one. Don't even worry about trying to memorize that. If you did, good for you. What is the normal myeloid to erythroid ratio in the bone marrow, or ME ratio in the bone marrow? 2.1 to 4 point, sorry, 2.1. 2 to 1 to 4 to 1, or 1 to 2 to 1 to 4, 3 to 1 to 5 to 1, or 5 to 1 to 10 to 1. Ooh, we getting a lot of responses here. C, B, C, A or B. All right, so we got A's. We're getting a lot of C's. All right, we can go C and see what it's talking about. Oh, damn. Who said A? Who said A? Nilab? You be getting them all right today. This was a level 6. I'm kind of shocked. In the bone marrow, the ratio of myeloid cells to erythroid cells ranges from a 2 to 1, so myeloid to erythroid, 2 myeloids to 1 erythroid, to 4 myeloids to 1 erythroid in healthy individuals. When segmented neutrophils are included in the myeloid count. Oh, okay, well, nobody told me that segmented neutrophils were included in the myeloid count. All right. If segmented neutrophils are not included in the count, the ME ratio or the ME reference ranges between 1.5 to 1 or 3 to 1. Okay, well, that wasn't one of our answer choices. So 2 to 1 to 4 to 1. If we're thinking about myeloid to erythroid ratio in the bone marrow, an iPhone 806, is that Caitlin? Is that you? Um, Myeloid to erythroid ratio is 2 to 1 to 4 to 1. Bet. Last one, y'all. Because erythrocyte lifespan is 120 days. Explain that. 2 to 1 to 4 to 1. And then associating that with 120 days. I'll come back to you, Nilab. An individual with group AB blood does not have which of the following antigens present on their red blood cells. So an individual with group AB blood does not have which of the following antigens present on their red blood cells? A, B, H, or O? A, B, H, or O? An individual with, yes, lean. O is not an antigen, right? It's okay. We call someone group O denoting that they lack both A and B antigens. It's okay. But since there's A and B, and the start of that is the H with the terminal sugar of N-acetylgalactosamine and then galactose, so they would lack that H. Oh, what? It was O? Damn. Damn. I'm sorry, guys. I fucked you guys up. It is. It was O. Damn. I'm fucking up. That's crazy. Ebony's like, oh. Okay. I'm gonna give you guys credit where it's due because you got me on this one. An individual that has A and B has genes for H, A, and B. Therefore, A and B antigens are present. The H antigen is the precursor to the ABO antigen, so the individual would have the H antigen present, but there's a terminal sugar on the end of that H antigen. So that's why I'm saying it would it have, well, it has it, but like it's not pre like totally present. That's where my thought process come from. So my bad. The O gene is an amorph. This means that the gene does not code for a gene product, so there's no O antigen. Oh, duh. It wouldn't have O because O is not, it's not a fucking antigen. Ow, I'm hurting. My stomach hurts. Duh, because there is no antigen. Come on, individuals who are group AB do not carry a copy of the O gene since their ABO genes are that are present are A and B. Damn. Sorry guys, I fucked you up. See, this is the importance of reading the question, okay? Even me, 10 years in, I will still be like, "No, it's not the correct answer." But you guys got that one. I give it to you. I definitely give it to you. All right, that was a level 3. All right, so let's finish our exam. We scored an 80 overall. That's great. I like to see us scoring between a 60 and 80%, if not more than that. So the fact that we got an 80, Yes, we passed. Okay. Snap, snap, snap. We passed. All right. So we'll just go over some of the ones that we got incorrect. Let's see. Which of the following group B antigens is generally associated with a mixed field reaction? Do we remember which one that was? Mixed field reaction. Which of the following group B antigens? Yes, B3. B3 is the one that gives us a mixed field. And then, which of the following best describes myelodysplastic syndromes? Do we remember? Can anyone describe that to me real quick in the chat? Myelo, myelodysplastic syndrome. I know, guys, I'm sorry. I'm messing up. Um, yes, it's a lot of everything, but it's not it's not an overproliferation of something. It's a qualitative or quantitative defect, right? Because the bone marrow is not able to, let's look at the answer here. Come on now. What's going on? All right, so it's a qualitative disorder of the erythroid myeloid and or megakaryocytic cell series. The myelodysplastic syndromes in the bone marrow stem cells cannot effectively make erythroid myeloid megakaryocytic, can be due to qualitative or quantitative defect, leads to AML or acute myelogenous leukemia. Thinking about all of the colors on the all of the colors on the slide. All right, let's go back. What was the other one? Okay, platelet products will be prepared from a whole blood donation. What must be used? Yes, a diversion pouch. Okay, a diversion pouch. Don't come for me. And then this last one is gonna kill me. I should post this. I'm recording right now. I'm gonna post this. See, even students fuck up. I mean, even teachers fuck up. Okay. Normal myeloid to erythroid ratio in the bone marrow. Tell me, tell me, tell me. Normal ME ratio in the bone marrow. Lab 4 to 1, 2 to 1, 2 to 1, 4 to 1. Yes, perfect, perfect, perfect. Gene translocations. Yeah, we're not even going to worry about that. But pretty much you guys did really well on this one. I feel like you have a strong hold on hematology. Let me stop my share here. Stop share. Okay. Um, y'all can see me. You guys have a really good hold on blood bank and hematology. We'll try to do this again next month. Since I'm on a break from work, we can really do some more here. If there's any particular cheat sheets or anything that you need, definitely put it in the chat. And then I'm gonna put it on sale again just because every time I do this, I'm like, you guys could really benefit from coming in to my inner circle community, the inner circle of microscope views. I'm doing this every single week. This week I'm actually having two study sessions, so I'm having one on Saturday and Sunday if you join. And then I'm having one next Sunday, and then the following week I'm having two again, and then the following week one. So I've been doing a lot more of these in my inner circle community, and I put a lot more resources in my inner circle community. So I have flowcharts, I have all of the diseases that are tested for chemistry, their lab results, their genetic, yeah, cheat sheet for blood bank. That's what I'm actually working on right now. So I'm in the process of compiling one for each section, and then I'm also in the process of compiling one big one so you can just have it on one big sheet. On top of that, I was very PG today. I typically curse a lot more and I typically say a lot more ratchet things, but I have some microcharts if anyone wants them. They're so helpful. How can I share them? If you're in the community, just post it in the community. Say, hey, um, these are charts that I found helpful. If anybody wants them, just share them. You're able to post a link. Um, and then the cheat sheets are on school, yes. So in the free community, I don't have too much in the free community, just because I put a lot more time into the paid community, and that's where we have a lot more interaction. And the link for that one is in my bio. If we are doing the same on our own in regards to the questions, are we good? Yes. So if you're doing what I was doing today, talking out loud, going diving deep into stuff, if you're chat GPTing, this is your time to not be bashful. This is your time to be like, okay, I don't know the answer. Okay, enlist the help of chat GPT, enlist the help of Google. Understand the who, what, when, where, how, why everything is happening, the disease process is happening, okay? And if you're scoring This is my personal experience, and this is what has been happening for my students. If you're scoring between a 60 to 80%, if not more, on Lab CE Media Lab, you have a very high chance of passing the real thing. Okay? On all of your practice, if you do 10 questions, you get six or more right, golden. I'd like to see that number about eight or more high or eight or more right, golden for sure. Okay. I don't know too much about the ASCP BOC or like what's that other one, the purple or yellow book or the flashcards, whatever floats your boat to use, but I do know that lab CE, because of the high level of difficulty of the questions and because it's you can do a computer adaptive exam and you're on a device, right? You're literally on a device just like you're going to be on a device when you're in the real thing. So if you're practicing as you're going to perform, you're going to feel a lot more calm. So, do you have suggestions for test anxiety? Let's start with how many of us are women and men of faith, whatever faith that may be. We're gonna go into a little preach, okay? The church is gonna come, okay? If you are a woman or a man of faith, let's start with God, Allah, the Most High, did not bring you this far for no reason, okay? Trust in the Most High that you are here to get across the finish line. Okay? You have all this knowledge. You just went through a rigorous program to get here, and now you're finally eligible to take this exam. Girl, give thanks and praise to the Most High that you are here and you can do this. You wouldn't have passed through school. You wouldn't have gotten this job if it wasn't for you being capable. You know what I'm saying? So I really want you to think for test taking anxiety, Kenya, and lean, seriously, really lean into a higher power. If it's God, if it's Allah, if it's whatever, you know what I'm saying? Really lean into that because you wouldn't be here if it wasn't for that. Period. Okay? We wouldn't be here all together in this moment if it wasn't for that. And trust in God that He's granted you the wisdom, the discernment, okay, to answer these questions. You have all this knowledge. You just learned all this, okay? Just trust in the Most High. How often should we be doing the full 100 questions? Depending on how far out you are for your exam. If you have 1 month out, you should be doing one every week, if not more than one, at least two per week if you're 1 month out. If you are 3 months out, I would say every other week. Desi takes her ASCP exam tomorrow, or he or she, sorry, I said she. You take your ASCP exam tomorrow. How do you feel? How do you feel? Don't be nervous. Just like we were just talking about it. Trust in the Most High, okay? You absolutely got it. You absolutely got it. Just take a moment to take a breath before you go in. Know that you already got this. See yourself already with that big ass pass across the screen and walking out crying that you passed, okay? Giving thanks and praise. You absolutely got it. All right. Well, if anybody else has any other questions, please feel free to message me on school or Instagram or TikTok. I appreciate you guys being here so much, and I will see you on the next live.